Okay, so thank you so much for being here. Our webinar today is on managing syphilis, providing clinical care in the era of Bicillin-LA shortages. It's being presented by Dr. Jason Zucker. Dr. Zucker is an assistant medical director of the New York City STD HIV Prevention Training Center and an instructor in the departments of medicine and pediatrics in the Division of Infectious Diseases at Columbia University Medical Center. So Dr. Zucker, I'll turn it over to you.
All right, good afternoon, and thank you all for joining to talk about this important and timely topic. Let me just get my slides up. Can you see my slides?
Yes, looks good.
Great. So I have no personal disclosures. So the goals for today, and it's a lot of goals for 30 minutes, but we hope to be able to recognize the importance of screening for syphilis, accurately classify syphilis by stage, summarize recommended treatment options, develop plans for management during the Bicillin-LA shortage for your clinic, and understand appropriate syphilis follow-up. So I'd be remiss if I didn't start by describing how we ended up in this situation. In April, the Centers for Disease Control released the 2021 State of STDs in the United States, and for the 7th year in a row, syphilis cases continue to increase. We now have over 176,000 cases of syphilis, a 74% increase from 2017, and a staggering 2,855 cases of congenital syphilis, a 203% increase from 2017. And I can tell you already that the 2022 numbers will be worse, likely over 3,000 cases of congenital syphilis. Before I dive in, I always like to highlight that it didn't have to be this way. The last syphilis epidemic peaked in 1990, with the highest syphilis rate in 40 years, which you can see marked by the blue arrow. After that, control measures were so effective that by 1999, there was a national goal to reduce primary and secondary syphilis cases to 1,000 or fewer, and increase the number of syphilis-free counties to 90% by 2005. As you just heard, we did not meet that goal. Instead of having under 1,000 cases, we have over 176,000 cases per year. And I placed a blue arrow over the peak from 1990 and a green arrow from our current day. And as you can see, we're probably closer to the peak from 1990 than we are to the goal of elimination that was planned for 2005. This second chart shows the same data, but blows up 2012 through 2021, so you can better see the dramatic rise in cases of total syphilis during the most recent period of time. And in case anyone thinks this is not a New Jersey problem, New Jersey is firmly in this lighter blue color right here, with the second highest rate of syphilis cases, a significant increase from 2012 when we were this nice yellow color at the bottom. In terms of syphilis rates, this is primary, secondary, and latent syphilis over time in New Jersey from the New Jersey Department of Health website. And you can see that cases have increased steadily from 2012 through 2022. And so like all infectious disease outbreaks, if we want to reverse these increasing trends, we need to test and treat more people. These are the current CDC recommendations for syphilis screening, and they include screening men who have sex with men at least annually if sexually active, and every 3 to 6 months if at increased risk. Screening transgender and gender diverse people at least annually based on reported sexual behaviors and exposure. Screening patients taking PrEP at initiation and every 3 to 6 months based on increased risk. Screening patients living with HIV at diagnosis and at least annually, or every 3 to 6 months if at increased risk. I always like to highlight the fact that for cisgender women and non-men who have sex with men, there is no national recommendation for routine screening, and it just says to screen asymptomatic adults at increased risk for syphilis infection. Finally, for pregnant persons, we should be screening at the first prenatal encounter, plus 3rd trimester and at delivery if high risk or in an endemic area. Finally, I'm not sure that in the era of rising syphilis and congenital syphilis rates, that these recommendations go far enough. And I really recommend that you should consider screening for syphilis anytime you're screening for sexually transmitted infections. Now, remember that testing for syphilis is really only relevant for people who don't have clinical signs and symptoms of syphilis. To test for latent or asymptomatic syphilis, there's 2 algorithms available, the traditional algorithm and the reverse algorithm. The traditional algorithm starts with a non-treponemal test like the RPR usually, and if positive, uses a direct treponemal test for confirmatory testing. Just as a reminder, a positive confirmatory test shows evidence of syphilis infection, but this could be evidence of current infection or prior treated infection, and interpreting titers are critical for making that distinction, and we'll cover the interpretation of titers in just 1 second. This is particularly important in the era of drug shortages, because if your patient has a prior treated infection, that means you don't necessarily need to treat them and can save those antibiotics for others. The second algorithm is the reverse algorithm, which starts with a direct treponemal test, either an EIA or a CIA. If positive, it reflexes to a quantitative non-treponemal test. And if those results differ, you then perform a second direct treponemal test to break the tie. Well, I'm not going through the entire algorithms today. I am happy to take questions about them at the end if there are any questions. What is important is that both of these algorithms utilize a quantitative test, the RPR, that needs to be interpreted to know if somebody has a new versus prior infection. Syphilis non-treponemal quantitative titers are important. They're what allow us to assess for treatment success and failure, as well as evidence of treated or reinfection. Quantitative testing involves the serial dilution of serum specimens to determine the amount of non-treponemal antibody present. Some things to know: a 4-fold increase in the non-treponemal titer after treatment is always abnormal. And this 4-fold increase is what we consider necessary to demonstrate a clinically significant difference between two tests. So if you go from 1 to 16 to 1 to 32, that's only a 1 dilution or 2-fold increase or decrease in titers. Compare that as going from 1 to 8 to 1 to 32, or 1 to 32 or 1 to 8, which is a 2 dilution change or 4-fold increase or decrease in titers. As a reminder, non-treponemal titers usually decline after treatment and may become non-reactive with time. However, for many people, non-treponemal antibodies persist for long periods of time, even forever, a response referred to as the serofast reaction. And so what you're looking for to define adequate treatment is this 4-fold decrease in titers. Before we get to treatment, understanding adequate treatment requires us to understand the proper staging of syphilis. This is important because staging directly relates to how we treat, as well as how much treatment our patients require. This diagram is from the New York City STD Prevention Training Center and New York City Department of Health syphilis monograph. Jessica will put a link to that in the chat, but it highlights the stages of syphilis really well. Syphilis starts with the incubation period. After a recent exposure, you may not test positive and have no symptoms for up to 90 days. Therefore, individuals who are sexual contacts of partners with known or suspected syphilis should be considered for presumptive treatment as opposed to waiting for a test and treat strategy. After incubation is primary syphilis. Primary syphilis is defined by local symptoms, traditionally the painless chancre that we think of as typical for syphilis. But it's important to remember that because these are painless ulcers, if they're not in an easily visible spot, like they're in the rectum or vagina or oral cavity, they may not be noticed. And so patients may test positive without ever having seen their chancre. They're often associated with regional or bilateral lymphadenopathy, which may be an additional clue on physical exam. They tend to occur 10 to 90 days after infection, are highly infectious, and resolve within 1 to 6 weeks. Primary syphilis also highlights the importance of doing a complete physical exam in order to better stage syphilis, as again, staging can impact how much treatment we provide patients. One other thing to remind people is that in the updated 2021 STI treatment guidelines, they did highlight that we're seeing more atypical presentations of syphilis, patients with multiple atypical or painful lesions at the site of infection. After primary syphilis is secondary syphilis, which is disseminated. This is what we traditionally think of as rashes on the palms and soles, but also includes other disseminated symptoms like disseminated rashes all over the body, generalized adenopathy, fevers, chills, fatigue, hepatitis, and other symptoms. It generally occurs 4 to 8 weeks after infection, resolves in 6 weeks, and is highly infectious. This is a table from that monograph I mentioned earlier that outlines just some of the many potential manifestations of secondary syphilis. Finally, latent syphilis, which we talked about a little bit earlier. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document non-reactive syphilis serology within the past year, or a history of symptoms of early syphilis within the past year. Otherwise, the disease is considered late latent or syphilis of unknown duration. And again, these designations are important because they determine what is adequate treatment for syphilis. As a reminder, because this is often confusing, latent syphilis requires no exam findings of primary, secondary, or tertiary syphilis. This is commonly confused, but for patients with clinical signs of primary or secondary syphilis, they do not need treatment for late latent or latent of unknown or syphilis of unknown duration, regardless of the date of their last syphilis test. And all of what we've discussed so far plays into treatment for syphilis, which is determined by stage. Here we have the CDC recommended treatment and alternative treatment options. For incubation, primary, secondary, and early latent syphilis, it's a single dose of benzazine penicillin G, or alternatively 14 days of twice daily doxycycline. For late latent or syphilis of unknown duration, as well as non-neurotertiary syphilis, it's benzazine penicillin G weekly for 3 weeks, or doxycycline twice daily for 28 days. And finally, for neuroocular and otic syphilis, it's IV penicillin for 10 to 14 days, or IM penicillin for 10 to 14 days with probenecid. This brings us to the challenge that we're facing today. The FDA currently reports a shortage of benzazine penicillin G from the manufacturer, with an estimated recovery time of early 2024 as of right now. What's interesting is that unlike many other antibiotic shortages, this one is being driven by increased demand. It's likely because we're having increased cases of syphilis, but additionally at our institution, we saw an increase in the use of intramuscular penicillin for group A strep. Many may remember or have heard on the news that in the US in the spring over the summer, there was a large increase in group A strep, which further increased demand for these products. However, this means that because it's a demand issue and not a production shutdown, that penicillin G is still being produced, and it is possible to get supplies, although sparingly. And that really plays into how we're managing during this shortage. However, before I talk about how to manage during the shortage, there is one more thing you should know. And that's why I mentioned earlier that in some cases, intramuscular procaine penicillin could be a potential alternative. Recently, this was discontinued by the manufacturer, and so will not be an option moving forward. And that puts us in this uncomfortable position. Benzazine penicillin is on shortage, and IM penicillin is no longer manufactured, leaving us only oral doxycycline, procaine penicillin is no longer manufactured, leaving us only oral doxycycline as alternative options. So how should we be managing syphilis during the shortage? The first thing is that we need to monitor supply and forecast need. And I'll tell you that this is something we had a challenge with even at my own institution. You need to be constantly taking stock. And this is a medication that staff is not used to worrying about because they figure they can always reorder. So it's important to meet with your pharmacy team or supplier, understand your current supply, understand current availability, and adjust internal recommendations accordingly. Second is the importance of appropriately staging syphilis. As I mentioned a few times earlier, a thorough physical exam is important to accurately stage syphilis. Primary lesions are often hidden inside the mouth, anus, or vagina, and signs of secondary syphilis may be found on the skin, and the rash can be subtle. However, you can find evidence of primary or secondary syphilis, and you may be able to do just a single shot of benzazine penicillin G, as opposed to 3 shots, saving 2 dosages. In addition to physical exams, getting a thorough history is important for appropriately staging syphilis. This is something we see not always done because sometimes it's easier to tell a patient they need 3 injections than try to get the history and prior labs needed to accurately stage them as early or late syphilis, or latent syphilis. However, now is the time to spend more time trying to get the information needed to stage syphilis, as early or late latent syphilis affects the duration of therapy. If you can stage people as early as opposed to later unknown duration, they can get 1 dose instead of 3, again, saving 2 dosages. Finally, don't forget about reviewing signs and symptoms of their sexual partners and their history for the last 12 months, as that can even further help with determining the likelihood of timing of syphilis acquisition. Finally, prioritization is critical right now. The CDC recommends prioritizing benzazine penicillin to treat pregnant persons with syphilis and babies with congenital syphilis, as penicillin is the only recommended treatment for these populations. Otherwise, you can choose doxycycline for non-pregnant persons to help preserve benzazine penicillin supplies. Some ways that places have done this are to work with your antimicrobial stewardship leaders to institute system-level approaches to limit the use of benzazine penicillin and encourage the use of alternative effective antimicrobials for treatment of syphilis like doxycycline. So here's an example from where I work. We developed a drug alert that went out to all providers. The alert included a description of the problem and then included the following. 1, we utilized our existing antimicrobial stewardship program to ensure that ID approval was needed before a dose was dispensed. We paired that with providing recommendations for how to treat syphilis without benzazine penicillin. And finally, we provide alternative treatments for other diseases. For an example, this chart shows our current recommended management of syphilis. As of the time we wrote this, we had a greater than 60-day supply. And so we recommended using doxycycline for exposures and for late latent or syphilis of unknown duration, while continuing to use benzazine penicillin for primary, secondary, and early latent syphilis that may be more contagious. Our next step, if the shortage continues, is to switch primary, secondary, and early latent syphilis to doxycycline as well. In addition to syphilis, we also provide recommendations for group A strep, which, as I mentioned earlier, was a common other use of benzazine penicillin. And this is what we provided them in the letter. But we also developed a larger table for the emergency department that was able to account for patients who are unable to tolerate oral medications or patients who might have anaphylaxis to penicillins or cephalosporins. And these tables will be available when we send out the slides after today's presentation. So those are our formal recommendations. But I want to also highlight things I frequently get questions about that are not recommended alternative therapies. This includes ceftriaxone, azithromycin, and amoxicillin with or without probenecid. The first is ceftriaxone 1 gram IM/IV for 10 days. It is included as an alternative treatment in the British guidelines, but is not recommended in the CDC guidelines. And that's really because there's limited data on its effectiveness, and the optimal dose and duration have not been defined. It does say that treatment decisions should be discussed in consultation with a specialist, and there may be circumstances where ceftriaxone is used, but it's not a preferred or recommended agent for syphilis. The second agent is azithromycin 2 grams. And people remember this one because it used to be in prior iterations of the guidelines. However, due to mutations associated with macrolide resistance, the CDC actually recommends now that azithromycin not be used as treatment for syphilis. Finally, amoxicillin with or without probenecid, which is in the British guidelines as an alternative regimen and is used pretty regularly in Japan, has gotten some interest of late because of this recent CID article. And the IDSA actually published a really nice graphical abstract of this study. As you can see, serological cure rates for early syphilis within 12 months were about 98% and 94%, with the combination regimens and low-dose amoxicillin groups, respectively. This study did show high rates of effective treatment for both amoxicillin with or without probenecid. However, this is newer data, and amoxicillin remains not recommended in the CDC guidelines. Finally, it's a reminder that for pregnant women, treatment is the same, but that we don't use alternative regimens in pregnancy. For women with a history of penicillin allergy, they recommend desensitization and treatment with penicillin. And this is because non-penicillin regimens are either contraindicated in pregnancy, like doxycycline, lack sufficient data for efficacy, like ceftriaxone, or don't cross the placental barrier completely, like azithromycin, and therefore are not recommended for pregnant women. Otherwise, treatment looks just like that for non-pregnant patients. However, there is one additional difference, and this is what to do about missed doses. So for patients who are non-pregnant, clinical experience suggests that 10 to 14 days between doses might be acceptable before restarting. An interval of 7 to 9 days remains preferred, but 10 to 14 days would be considered acceptable. That's not true for pregnant persons. Missed doses greater than 9 days are not acceptable for pregnant persons receiving therapy for late latent syphilis. Pregnant persons who miss a dose of therapy should repeat the full course of therapy, and that holds even in this time of benzazine penicillin shortages. In terms of follow-up, this is an area where we can also save more treatment because a lot of people try to retreat too early. Failure of non-treponema test titers to decrease fourfold within 12 months after therapy for primary or secondary syphilis may be indicative of treatment failure. If you're looking for signs of failure, you're really looking for clinical signs and symptoms of syphilis. You're looking for a fourfold increase in non-treponema testing for greater than 2 weeks, or a failure to see a fourfold decrease after 12 months. And we'll talk about what to do if you see a failure to decrease after 12 months after this. But just as a reminder, it can be a long time for titers to decline, and we should be patient waiting out that 12 months. Additionally, 10 to 20% of patients will not achieve a fourfold decrease in titers within 12 months. And we know that, so not every patient will have that decrease. For latent syphilis, it's actually 24 months. Again, clinical signs and symptoms or a fourfold increase in non-treponema testing would be signs of failure. Otherwise, failure to see a fourfold decrease after 24 months. One thing to note, though, that it's more common if the initial titer is low, that we don't see that fourfold decrease after 24 months. If you're failing to see a fourfold decrease after the appropriate amount of time, we need to think about what to do for treatment failure, quote unquote. Conservative management says that we can continue to follow serology annually without retreating. We should do a clinical and particularly a neurologic exam and consider an LP if the neurologic exam is abnormal. We also want to repeat HIV testing as patients with HIV have a slower decline in titers. And if additional follow-up cannot be ensured, that's when we want to consider retreatment. So we really want to be patient and not retreat people too quickly. As a reminder, I'm from the New York City STD Prevention Training Center. If you ever have a question about syphilis or any other sexually transmitted infection, we're available through the clinical consultation warm line at stdccn.org. And I'll stop here and take any questions. Thank you very much.
Thank you so much, Dr. Zucker. That was fantastic. Just as a reminder for everyone, if you have any questions, please use the Q&A box, which is at the bottom of your Zoom screen. So we'll give folks a couple minutes to drop some questions in there. And there are a couple of resources in the chat. One of them is the syphilis monograph that Dr. Zucker mentioned, which you can find on that first link there via our website. And then the second link is the STD CCN warm line that Dr. Zucker mentioned. So any patient questions, difficult cases that you have that you'd like some support, feedback on, please feel free to submit those cases through that link. We'll get back to you within 1 to 5 business days, and that'll be somebody from our team, possibly Dr. Zucker, who will answer those questions. All right, we have one question here asking Dr. Zucker, can you compare the efficacy of penicillin versus doxycycline for syphilis?
Yeah, so, penicillin remains our treatment of choice because it's a lot less dosage and a lot easier to do. If people take doxycycline as directed, twice a day for 14 days or twice a day as 28 days, it's thought to be nearly as good as penicillin. The challenge is getting people to take it for the complete course. Obviously, single IM penicillin versus even 14 days twice daily of doxycycline is much more challenging. And yes, the slides will be made available, and Jessica will send them out after this presentation.
Yep, thanks for that. Yes, we will be sending the slides out later today, and I will also let everybody know once the recording is available online. Any other questions from folks? We've got Dr. Zucker here, so any questions you have, please feel free to drop them in the Q&A box. All right, one question here. For the 4 milliliter syringe, do you recommend 1 injection or split it into 2?
Yeah, Patricia, can you clarify a little bit what you mean by the 4 ml? So the 4 ml pre-filled syringe, is that what we're talking about here? So we generally do it as a single injection. However, other people have done it as split injections to reduce how painful it is. We generally do it as a single injection, although patients have requested it to be split before.
Great, thank you. Okay, well, if there are no more questions, oh yes, Patricia said thank you. So I think that did address what they're asking. If there are no more questions, we can wrap up a few minutes early. Just want to thank you all for spending this time with us today. Really appreciate it. Thank you, Dr. Zucker, for the presentation. As mentioned, we will be sending the slides out later today, and I'll also be letting folks know once the recording is available on our website. As Dr. Zucker mentioned, we're expecting this shortage to continue into next year. So if questions come up in the meantime, you can always reach out to us first via that STD CCN warm line. So thank you, everyone. Hope you have a great rest of your day.
Thanks, all.